As many of you are aware, the Czech AIDS Help Society is doing a lot of work in HIV, especially in the way of prevention of STIs. And today we are here for the lecture with our special guest, whose visit in Prague was funded by the program, Fulbright program. And it is my pleasure to introduce Professor Jeffrey Birnbaum, yes, from New York. And Jeff is the professor of pediatrics and public health in the sunny downstate Health Sciences University, Brooklyn. And today he will share with us his experiences. Jeff is also the executive director of special program for teenagers. It's called HEAT, and he will tell us more about it.
Yes.
We do also like to greet our online viewers, and I believe we are going to have special time with you, Jeff. We are very happy to have you here, and the floor is yours.
Thank you.
Thank you.
Thank you.
Thank
Milan.
you very much.
So, dobrý den. Did I say it correctly? Yeah. So, thank you, Milan and Sophia and Michal, for arranging this wonderful experience for me. I first came to Prague 30 years ago, and I worked at Bulovka with Michal, learning about earlier days in the AIDS epidemic. And let's see, we were supposed to do this in 2020, April 2020, but got sidetracked by COVID. So here we are in 2026. So welcome and thank you all for coming. And I hope if there are any questions, don't be polite, just raise your hand, feel comfortable interrupting me to clarify something. And welcome everybody online. I'm told there are some people who might be logging in from Brooklyn, people at the HEAT program in Brooklyn who might be watching. So hi everybody, and let's go. So today I hope to walk through some comparisons between the epidemiology of HIV as well as PrEP, which is the focus of our talk, comparing what we do in New York City and New York State to what you folks do here with PrEP and Lighthouse and all the other PrEP centers and HIV centers around Prague and the rest of the country. And I hope to spend a little bit of time talking about different populations that we serve, not just gay men, but other populations who are at risk for HIV, and maybe ways in which we can improve services for a wider variety of populations. So the devil is in the details of how to integrate PrEP services. As we were talking, Milan is on this multidisciplinary national group that tries to figure out how to integrate new ideas into PrEP services in the country here. So maybe it's possible to learn from some of our experience how we do this, at least in New York, not necessarily the entire USA. It's a big country where our HIV and PrEP services are different from state to state and city to city. Some places are very good. New York is one place that is excellent, and there are other places where it's not as well funded, and people really have to struggle to put resources together to take care of people. And what are the barriers? And how do we get past the barriers? Okay. Barriers are when the PowerPoint doesn't work. Oh, there we go. Okay, so my clinic is called Health and Education Alternatives for Teens, which stands for HEAT. We have this nice fancy logo. I'm wearing the HEAT t-shirt underneath my suit here today. We really deal with people under the age of 30, not just teenagers. And you'll see why in a moment. So I'm going to walk you through some of the epidemiology in New York City. So this is new diagnoses during this 5-year period. And you could see among this age group, it dipped down around COVID, which you'll see very similar trend happened in this country when I get to that. And things have started to come back up again. What happened in 2020 is the whole infrastructure for testing and care and connecting people from point A to point B kind of fell apart for several years. So it's not necessarily climbing, it might be, but it's more likely that people are coming back in for care and services, coming back to pre-COVID existence, so to speak. You see here, 20 to 29-year-olds is the largest group. That group are people who are most likely became sexually active when they were much younger. In this 13 to 19-year-old age group, where many people don't get tested in that age group, don't access any services whatsoever, there's a sense of invulnerability, and so don't necessarily access healthcare services. Therefore, their numbers tend to be smaller, but they kind of jump up to the largest group when they hit age 20. You could see how we spread out, how we look at the epidemiology, where to focus services based on where people are testing positive within New York City. And then we look here at the different genders involved. You notice it's not just men and women, it's transgender women here and transgender men. Transgender women tend to have similar risk profiles from condomless anal intercourse, receptive anal intercourse. I believe when I took the checkpoint and prep point quiz today, the term was passive intercourse. And so the risks are very similar, but the needs are that much higher. It's an invisible population. And I would postulate, I don't know this for sure, that they are probably here somewhere in Prague. They're probably somewhere an invisible population that kind of hides in the shadows, which is something that happens in the United States as well, but New York City is somewhat generous to these folks, accepting them as human beings and providing treatment. We have ethnic disparities. Who are the people who are carrying the burden of disease in New York City? It's largely Latino and Black, African American, Afro-Caribbean populations who are getting disproportionately infected compared to white and other racial groups. And again, this is New York City. And this is primarily among all people in this age group. When we look at men who have sex with men, again, same age group, 20 to 29, Latino and Black men. And when we look at women, the numbers are smaller, but the trends are very similar. We see 20 to 29-year-olds. There's this, I hate to use the word competition between the 20 to 29-year-olds and the 30 to 39-year-olds, but this is women of childbearing age. So they're getting disproportionately infected compared to other age groups. And again, Black and Latino women getting disproportionately infected with HIV. And you will only find data like this maybe in a few other places other than New York City. The larger state of New York does not collect data on transgender individuals. You can see relatively small numbers, but the trends are the same. You have 20 to 29-year-old people who are more sexually active than older folks. And it's, again, condomless anal receptive sex among transgender women. These are individuals born male, have male genitalia, and are having similar sexual practices to men who have sex with men. And again, it's Black and Latino transgender individuals who are getting infected with HIV. And I'm proud to say, and I'll show you some data later, that this is the population that I really work with, both among the men who have sex with men and transgender women. I'm serving large numbers of people from mostly the Black group, but also the Latino group. So what's going on here? Now I feel a little bit intimidated because I'm talking to you about your country. Well, we'll see. Feel free to jump in with questions. So, okay. I'm learning how to say it, not Czech Republic, but Czechia. Yes? So if you look at the color scheme, 15 to 19 and 20 to 24, it's a relatively smaller percentage of the folks who are getting diagnosed with HIV in this country. Again, I could say that as you get older, a lot of these folks in this group became sexually active, may have been infected at younger ages, but they're not getting diagnosed until they're 30 to 39 years old. Whoa, what just happened? Oh no. Slide explosion. Okay. So this I found really interesting because my impression, and I believe after talking to my colleagues here, I believe that what's going on here is that this includes all of your Ukrainian refugees, because my impression was that the epidemic here in this country was largely among men who have sex with men. And here you see it's slightly men who have sex with men. This blue line is less than half. So you're seeing a lot of imported cases among heterosexual men, heterosexual women. Injection drug use is there, and not that much. And for all of these countries, what I noticed missing, which again, we don't see in most of the United States in epidemiological reports, is transgender individuals. And I'll keep it a little clean in the way I say this. Right now in this country, it's hard to talk about that. In my country, it's hard to talk about that population because of some political realities we have to deal with. So I don't know if this is a shock to some of you to see just the volume of cases, but this is from European CDC. And similar, this is at least among men. We see this falling down among all age groups around 2020, having to do with COVID, and then it slowly creeps back up. So in December, in this country, there was a spike, 293 new cases, largest cities in the country. While there's a low infection rate, all of a sudden, there's this new influx of cases, and it seems that a lot of people are coming as refugees from Ukraine, and you have a very, I would say, compassionate or welcoming position towards Ukrainian refugees. You're inheriting their problems, and I know from everything I've been hearing, you're also very generous in this country to take care of these refugees and their medical problems, although it's not without problems. In terms of cost and medication and so on. But it's a problem that has to be addressed, and this is a spike. And it says that, out of these 293 infections, about only half of them were Czech citizens. The rest of them were foreigners living here, predominantly from Ukraine, Slovakia, Brazil, Moldova, and Russia. So I started to look at how is the system set up here? And this was a report that Milan's name was on. He didn't even know it. He's listed as the clinical contact. But I took information from the European CDC just to describe what Czechia's HIV program looks like, and compared a little bit to neighboring countries such as Poland and Germany. Border on these countries. And we also looked at, I'll also show you how France is a bit different. But you could see that sexual health is provided by clinicians, infectious disease specialists, venereologists, which is a totally foreign word to my thinking. We don't have this specialty in the United States. It's usually an infectious disease specialist that would treat venereal diseases, gynecologists. Not many general practitioners from what you've been telling me, something you'd like to see. and that all these costs are covered by compulsory health insurance. And really, the program that you have here set up is largely focused on serving MSM population. Now you have folks who are bringing HIV into the country who are not necessarily in this group, so maybe that's something to think about, or I know you've been thinking about it from what you've been telling me about how to provide care, especially for all these Ukrainian refugees and their imported cases of HIV. We have the HIV specialist model, community-based model as we have here in this building, and had a wonderful tour of what goes on in this building. I was really impressed at the lighthouse here. What's interesting is that the clinical exam and the laboratory tests are paid for by public health insurance, but the client has to pay the cost of the drugs, and it seemed like in most of the sources I looked up, this was about an average cost for the PrEP drugs per month. And so there's some limit on PrEP accessibility here, and from, as we've been talking about, making it more accessible through GPs and so on, that could be something that you would consider here in this country, because risk goes on everywhere, not just for people who come to HIV clinics. And it seems like there's not a lot of uncontrolled purchases over the internet as we see in other countries. Like in the United States, people are buying drugs from overseas online. A lot of these drugs come from countries where they may not have quality control, or you just don't know what you're getting. But it's good that people are able to pay for it here. So let's compare to Poland. Poland, very similar in that it's just focusing on men who have sex with men. These other categories are here, but are not checked off in terms of populations that are being focused on. And in Poland, you see men who have sex with men make up a much larger percentage of the population, but you do have heterosexual spread of HIV, and looks like slightly more with people who use injection drugs. And in Germany, this was interesting. They started out with a program that just is focused on men who have sex with men, but they have guidelines, and it's in their public health laws, that it's based on risk behavior rather than coming from a specific group. And they're saying here that they're looking at how to reach other groups of folks, such as female sex workers, people who inject drugs, migrants, including, and refugees as well. So there's Germany's spread of the who's getting infected with HIV. Again, a larger population of people who inject drugs. And then France. France had all the boxes checked off, which is similar to what you might see in New York City. And again, there's a lot more heterosexual spread of HIV in France, with men who have sex with men being the largest group in total. Okay. So what did this report highlight? I highlighted it in yellow. Is that there's a lot more heterosexual transmission than people necessarily are thinking about. Although sex between men is still the predominant mode of transmission, so all that programming that you have in place here, in places like this building, where condoms are being given out, lubricants and so on, testing services, PrEP, etc., and rapid initiation of treatment of HIV is something that is important and is in place. They were suggesting that injection drug use is, in terms of HIV, is relatively lower because there's a lot of harm reduction services that are still in place and have not been dismantled as they have in some places of the world, which I won't name, but I happen to come from. In many places in the United States, it's very taboo to have harm reduction services. And then I was very pleased to see here gender-affirming PrEP systems in this European CDC report, including transgender people, but gender affirming would also include PrEP for women, cisgendered women. Okay, and then finally, countries across Europe. When you have a program that's really focused on one population, sometimes it's hard to adapt that system to include other populations, especially if all of a sudden there's a war breaking out in a neighboring country and you have a huge influx of refugees. You're not prepared for that. I think you've done a good job here in Czechia, but all these countries are claiming they're just not set up, their programs are not set up to serve this population. Sex workers, transgender people. In the United States, again, I serve a large transgender population in my clinic, young people who are transgender, so I have a certain bias in favor of taking good care of them. So if you notice, I might keep mentioning them. So that's one of the reasons why, but I noticed it was the third largest population, third largest complaint of countries that really don't know how to interact with this population. But also, gay men who have sex with men, there are 11 countries, both in EU and non-EU countries, that struggle with engaging men who have sex with men. All right, what is going on here? So this is a timeline. These are all the studies on the top that were used to prove that the efficacy of PrEP, and most of you are probably familiar with the original IPREX study, but you could see IPREX was an international study. FemPrep was a study in women. This was with heterosexual partners. Bangkok included lots of men who have sex with men, transgender women, sex workers, and so on. And all of the PrEP programming and guidelines in the United States, here I have the studies, down here I have all the guidelines and the approval of drugs, are based on these studies, starting in 2011 and 2012 when tenofovir, invented in this country. Tenofovir was first approved in the United States for PrEP. And you can see the guidance just keeps CDC guidance for heterosexuals, not just men who have sex with men, PrEP for intravenous drug users. The New York State coming up with its own guidance for PrEP, not waiting for the federal government to say how to implement PrEP in New York, but let's New Yorkers come up with this guidance. And as these guidances come out, it becomes entrenched in payment systems. It's considered standard. Insurance companies cannot refuse it, and so on. So I use these titles here, pre-youth era at youth era. And going back to January 2017, we had this AIDS Adolescent Trials Network study 110, which looked at young men who have sex with men between the ages of 18 and 22. Can we get them to show up for these visits? Can we get them to show up every 3 months to get tested for HIV, get tested for gonorrhea, chlamydia, syphilis, and so on? Young men 18 to 22. And that was followed up a few months later by a study in 15 to 17-year-old young men. A little bit more complicated because of the issues around parents and consent and research. So an 18-year-old in this study can sign their own consent to participate in a research study. 15 to 17-year-olds a little bit more complicated because to participate, clinical care is one thing, but research really requires parental consent. So it was a smaller study. It was done in less sites, but and I won't go into all the problems that they had with both of these studies, but as you might guess, the younger you get, the worse the adherence is to medication. So they had breakthrough, especially in the younger 15 to 17-year-olds, the breakthrough cases, when they looked at the serum levels of tenofovir in the blood by 12 weeks, nobody nobody in this study had an acceptable level of drug in the blood. But here, you could see we allowed minors to consent for PrEP at this age group. April 2017, which for me is a real game changer. Allowed me to do things before I was doing it, I was working my way around the law. You could write in the chart that parents are unaware of the young person's sexuality, and by asking for parental consent, they would risk getting kicked out of their home or physical violence from a parent and so on. So if you write that in the chart, you could allow somebody below the age of 18 to consent for their own PrEP and for their own HIV care, but it's really not legal yet. So in April 2017, it became legal. FDA approved it. And then we have the TAF version of tenofovir coming out in 2019. Then we have these two HPTN studies, 083, which was in men, and 084, which was in women and globally. These were the studies that led to the approval of injectable cabotegravir. What I don't have listed on here, just for reasons of space, was the approval of lenacapavir, not invented in this country, but was invented by a Czech scientist who we lectured with last week. Okay, I was lucky to find these two bottles online, written in Czech. So these are the drugs that are available that cost about 38 euros a month. I don't know about the Descovy, whether the price is similar, but here I know the Truvada is about 38 euros. Are you using Descovy here?
No, we do have generics.
The generic,
Truvada,
right, you don't have the brand name here.
and Descovy is not registered for PrEP use.
Yeah.
So, but we do have it for treatment.
Right. So what happened, I don't know exactly what year, the patent from Gilead on Truvada expired, which allowed generic companies to make generic tenofovir, emtricitabine, and so now it seems that what Gilead is doing is really promoting the use of Descovy. In the United States, here you say 38 euros. In the United States, this might cost $30 to $35 a month, the generic version. But if you were to buy this bottle, it might cost you, a couple of $1,000s. So they make more money off of this. In the age group that I serve, I mean, the advantage of the Descovy is it has less renal toxicity. In the age group that I serve, it's mostly younger, healthy bodies. We don't worry as much about renal toxicity. So we don't mind giving the tenofovir disoproxil as much. But as the drug company reps come around and give us samples of the Descovy, some patients might prefer it. There may be a family history of renal disease and so on, so we might want to use it, or it may just be patient preference, but then you have to fight with insurance companies to pay for a more expensive drug. So what about, here I talk about adolescents, and I include young adults in that, people below the age of 30, injectable cabotegravir, not available in this country for lots of reasons. But the 083 study was the first study on a global basis looking at the use of cabotegravir every 8 weeks, getting an injection versus standard oral dosing of tenofovir disoproxil. This study was done in men who have sex with men and transgender women only. And the companion study, 084, was done in cisgendered women. And this study found that bimonthly injections of cabotegravir were superior, and I'll say it from experience, superior in every way to oral medications. Why are they more superior? You don't have to worry about swallowing a pill every day. It's just in your body, and it's good for 2 months. All you need to do is show up for the injection. And some of the cases of breakthrough infection were explained by adherence issues. That means adherence to the appointment. We went and found your patient somewhere outside sitting on the deck, and the first thing he said was, "You missed your appointment." things like that. If you miss your appointment for the injection, you have a certain window period. We tell the patients 1 week, but from what we're told, sometimes you can go for as long as 4 weeks. But we tell the patients you have 1 week to get in if you miss your appointment. And they get all nervous. Otherwise, we're going to put you back on those pills that you hate taking. So, so similar findings in cisgendered women. So there's a catch to it that for a variety of reasons, someone might want to stop taking cabotegravir. They say, those injections hurt. They have a sore butt for a week or so. People, that's probably the main reason people stop it, or people can't make it in for the appointments. They have busy lives, or they just forget, or they're unreliable sometimes. So you have a waning level of drug in your bloodstream, which may be subtherapeutic if you get exposed to the virus, and that is a way resistance can develop. So if somebody is going to come off the cabotegravir, you want to make sure that they're taking oral tenofovir for 6 months to a year, unless they're getting back on the medication. So for adolescents and young adults, that's the biggest concern that we have, people who stop injections or don't show up for injections. And there are some people for this and for injectable treatment, if they just keep missing the injections, we say you're not a good candidate for this. Maybe just showing up is too challenging for you for whatever reason. Try not to be judgmental. We'll put them back on the oral medication, and then they'll beg us to go back on the injections because life is so much easier. So what about lenacapavir? This is a busy slide, so I'll walk you through it. Similar studies, they had Purpose 1 and Purpose 2. What's nice is that Purpose 1, they started with cisgendered women, and this was done in Southern Africa, South Africa and Uganda, and it was in the age group that I like to serve. They gave the injection. These are a novel class of drugs, capsid inhibitors, and it's given instead of every 2 months, it's given every 26 weeks, once every 6 months. And comparing that to daily dosing of oral tenofovir. Purpose 2 study was similarly structured, except the population was cisgendered men, transgender women. Transgender men, in my opinion, these are two very different populations with different HIV risks. And probably, if I was setting up this study, which I wasn't involved in, I would have put the transgender men up there with the cisgendered women, having more to do with vaginal infection of HIV, vaginal transmission of HIV. Anyway, so in the women's study, again, lenacapavir, the injectable, had 0 infections and was considered to be superior. The oral arm had 55 infections, and you can imagine, or you can just speculate that was all due to adherence issues. In the men's study, there were 2 lenacapavir breakthrough infections, and in both cases, these were in individuals who had other sexually transmitted infections at the time of the week 26 injection, and the oral arm, which seemed to have 9 infections, occurred in people with poor adherence. It was interesting looking at these 2 studies, although this had a smaller N, 55 infections versus 9 infections, the women had much more difficult time with adherence, especially where they did the study in Southern Africa, where there's stigma about taking a PrEP medication at all. The major side effects that we notice is injection site reactions, nodules, and pain. And we've had some people who have started complaining. Our second patient that we put on to lenacapavir started complaining about it causing pain. You have to give cc and a half, about an inch or 2, can I say inches in a metric country, lateral to the umbilicus, and it hurts for a really long time, so a lot of people stop taking it for that reason, or will complain about it and it doesn't seem to be responsive to nonsteroidals, NSAIDs, or acetaminophen, or that sort of thing. Patient only has to come twice a year. When I'm giving someone cabotegravir and they're coming in for an injection every 2 months, I'm testing them for STIs every 2 months. We do a lot of gonorrhea, chlamydia, and syphilis testing in oral PrEP patients, and we were talking about it's usually every 3 months. It's not that much difference between 2 and 3 months for when you do all these tests. When you stretch it out to 6 months, let's say they got infected with gonorrhea a month after they got their lenacapavir, you're going 5 months without it being tested. So it's recommended that you have an interim visit at the 3-month point between the 2 injections so that you can do more STI testing. And this was approved just about a year ago for PrEP. So what's going on with injectables, and this is just with cabotegravir. I would think lenacapavir would be even less on the radar screen here in Europe. But this dark green color, not a single country in Europe has really implemented. Yes?
Sorry, France has just implemented it.
All right. So they're moving from not yet implemented to implemented. So that's good to know, especially when you saw what their PrEP program looks like. I was kind of surprised to see in Great Britain, it wasn't available either. I tend to view Great Britain's programs very similar to the United States, so I was surprised to see that. But here, from what I've heard, and there are lots of reasons, in this country, it's probably just a matter of cost. There are other things to consider, workflow in the clinic of injectable medications and just securing them and dealing with insurance companies and so on. It's a lot of work. That's the current status, minus France, which is updated. Okay, so how do we fight in New York State? How do we fight the epidemic in New York State? We have a really great, what we call ETE blueprint, End the Epidemic, and there are 3 main points, and you probably have similar concepts in play here in this country. Finding out who's HIV positive and get them into care. All right? Makes sense. Once you have them in care, viral suppression. U equals, do you use that term here? U equals U? Undetectable equals untransmittable. So they're not going to spread HIV if they're in treatment and on medication. And then getting all high-risk people onto PrEP, providing it to them, and keeping them HIV negative. So what's going on in New York City? I describe New York City as somewhat of a blue utopia, a safety bubble, safety net for people, unlike other places in the United States. But in terms of the age group that I serve, we're doing a really terrible job. These are if you look at slides, the other slides, the HIV infection rates, these are the groups that are up at the top of the chart, but in terms of who's getting PrEP, they're the lowest, I don't say access, but I hate to use the word penetration, but penetration into the population of in terms of this age group, the lowest number of people getting it. Keeps me busy. Okay, so what do we do that's different in Heat Clinic? I told you I was going to talk about the Heat Clinic, and I hope some of the folks in the Heat Clinic are watching back home, but very youth-centered, multidisciplinary care. That means not just doctors, you have doctors, nurses, social workers, mental health people, young people, peers working in the clinic so that people feel comfortable and all of their needs can be taken care of in what we call a one-stop shop model. You get everything in one place. You don't have to refer them to the dermatovenereologist to get treated for the STD that you diagnosed. Just do everything in one place. And I'm going to have a nice case that I present of a PrEP case where, like, what one-stop shopping can look like in an extreme case. The providers really don't have contact in general with the parents. Youth don't disclose their healthcare status or their sexuality to their parents, so they need a place that they can go to. Frankly, if I was a 16-year-old teenager, I would feel comfortable coming to this building, but I might feel intimidated coming to the clinic at military hospital. Just the name military hospital is a little bit more intimidating. A place like here, and I loved your facilities, don't get me wrong. But this is set in the community, it's a little bit more discreet. And teen youth services are core to the clinic. And really, it's all about sexual health. You see, well, we have substance use here, dealing with rights to confidentiality and consent, treatment education and approaches. And this is called explanation of benefit issues. That's a problem I don't know if you have here, but if you're on your parents' insurance in the United States by law, and different states have different ways they set this up, the insurance company sends a letter to your house that's saying, so-and-so accessed these services. Here's an explanation of what we did. So parents will get this explanation of benefit letter, and they'll say, what? You got tested for HIV? What? You got a pregnancy test? What? You got tested for gonorrhea? What? You got treated for gonorrhea? So having to navigate around that is something that one person in particular on PrEP manages that, but we all kind of manage it and have to be aware of it. So having specialized HIV PrEP and sexual health services, since the problem is not that different from here in terms of dealing with LGBT youth. Like I said, I deal a lot with young men who have sex with men and transgender women. So being able to provide them with sexual health services that are specific to their needs, how to talk to them and so on. Being able to take care of them as well as heterosexual young women, partners of, we have a lot of perinatally infected youth, people born with HIV now living well into their 20s and 30s. They come in with their partners. And so sometimes disclosure of HIV status is an issue we have to address between them and the partner, as well as putting the partner on PrEP. So dealing with things in a youth-focused manner, talking to people in a way that they'll be receptive to the information. And then, again, dealing with minors and parents, knowing how to work your way around the consent issues, the laws in New York City. I'm a pediatrician by training, and I can tell you that pediatricians always misstate the law. They use the term emancipated minor. They're not emancipated. Emancipated means they live independently of their parents, completely independently. They're not emancipated. They're mature minors with a right to consent for certain types of sexual health care. How to work your way around the insurance system. And now, at least in New York, we still have what was once called Obamacare, and people under Obamacare in different states are on their parents' insurance up through age 26. Some of that is in the process, unfortunately, of being dismantled. But if you're on your parents' insurance and you're 25 years old, you may be mature enough to handle life on your own, but you don't want your parents knowing what your business is, because they're going to get the explanation of benefits letter. So knowing your way around that system is really important. Some of the challenges we face: there are limited numbers of clinics that serve young people. Young people are not just younger adults, even though I use the term young adult, especially the teenagers. You got to know where the adolescent, teen-friendly places are. Adult clinics usually have 10 times as many patients, busier waiting rooms. People look a little bit scarier in the waiting room. Again, insurance issues. In addition to knowing your way around the insurance system, these are PrEP app is PrEP assistance plan. I have another slide, I'm going to explain what that is. And this is treatment assistance plan, so that if you are trying to get the drug paid for and someone doesn't have insurance, you can ask the drug company, will you fill out some forms, do they meet certain criteria, income, and so on, to get the drug for free from the company. People, as I said, don't know that minors can consent on their own care. The minors themselves don't know that they can consent for their own care. General lack of information and stigma. So, the insurance system in New York State allows for PrEP app, which will pay for, it sounds like the check system here, it pays for the medical care but not for the drug. So it pays for the doctor's visit and laboratory tests. And this comes from New York State. If you're uninsured and you want to be on PrEP, this will pay for your PrEP care. It won't pay for going to the emergency room or treating your asthma or your diabetes, but it will pay for your PrEP. And you are eligible for this regardless of parental knowledge, regardless of your immigration status. You could be an undocumented immigrant. And in New York State, at least, you're eligible for this type of insurance. And then, we figure out how to get the drug otherwise, usually through an assistance plan is the most common way. And there are certain laws in place for even private insurers, that private insurers cannot deny coverage for PrEP services. It's against the law for them to do it. And if they say we don't cover that, you call up New York State Department of Health and cause trouble for that insurance company, and they quickly start saying something different when you tell them you're reporting them. There's this other dreaded concept in the United States, prior authorization, where the insurance company, you have to go through all sorts of processes to get it authorized, and then they could say, sorry, we don't agree with this, we're not paying for it. So that becomes illegal as well. And again, reporting violations. I love reporting insurance companies for violating this. And they, like I said, they don't want the state coming after them. They will approve it once you threaten them with that. These are things in New York State that a minor below the age of 18 can consent for. And this is all sexual health related, including abortion without parental knowledge. Outreach suggestions. So you need to maintain a clinic that's perceived as safe. Like I said, you can set up a program like this anywhere, but you need to have a mindset to have, if it's in an adult clinic setting, have a day or have a room or have a provider where people are a little bit more focused on the needs of younger people, younger patients. Where are these young people getting referred from? It's one thing to open the door and provide the services, but you need to know all the youth agencies in your local environment so that they will send people to you. We use LGBT youth agencies. Here, so this is an NGO. It's nice to say NGO because it makes me feel like I'm away from home. At home, we call them community-based organizations. Same thing. Foster care agencies, and so on. And one of my pet projects is offering PrEP along with higher risk transgender young people. Not all transgender young people are sexually active. Some of them are very uncomfortable looking at their own bodies, let alone sharing it with another person. So not all of them are sexually active, but the ones that are, the needs are that much greater and the risks are that much higher. So these are some of the, I took a whole pile of pamphlets from here. The Lighthouse is really great pamphlet literature for outreach purposes. But this is one, we used to be called SUNY Downstate Medical Center. Now we're SUNY Health Sciences University. We've graduated. And our logo, call this number. Someone at Heat will answer the phone and you'll get right into care. We try to use images that look like the population we serve, so it's you know, not by chance that he's a young black man. So that's the population that we serve most, that we're in the community, right in the middle of. This is ours, this images that have young men kissing each other. Again, they're young black men. This is interesting in that it is something that represents reaching out to something called the house ball community. This is what your son was saying I was talking about. So house ball community is popular among Black and Latino LGBT youth, particularly young men who have sex with men and transgender individuals. The concept behind that is that you're thrown out of your house, you're ostracized. The place where you grew up and the family that you were taken care of, you've been ostracized by them. You get no support from them. And so the house ball community offers you an alternative family structure. And they're not physical houses, they're more like clubs. They're alternative families. And you have a house mother and a house father, and you have house children. And all of these houses are named after different fashion designers. Anyone ever here seen the movie Paris is Burning? It's all about this subculture. And a television show, I don't know if it would be available on Netflix or one of the other streaming services, called Pose. It's all about this subculture and HIV in this subculture, in particular around Pose. And these houses become your family. You take on the name. You know, if my name is Jeff Birnbaum and I joined the House of Mulan, my name would become Jeff, or some other name if not Jeff, Mulan. And you take that identity very seriously, and you can really depend on these family members for support when you need it the most. And you better listen to the house parent. Otherwise, there's a price to pay for not listening. So the houses compete against each other in a venue that is referred to as the ball. That's where they have dance and fashion competitions, and you gain status in the house ball community by winning a prize at the ball in a certain category. And so here, these individuals are doing a type of dance called voguing. And there's a Madonna song called Vogue. If you've ever heard this song, that's where she got it from, the house ball community. Anyway, that's a very long story to tell you that we do a lot of work at Heat with the house ball community and try to promote ourselves as the provider of choice for young people in the house ball community. There are some estimates that up to 50% of the people in the house ball community are HIV positive. 50. So it's not an easy population to do epidemiologic studies with, but the limited information out there is it's as high as 50%. So you really want to focus on this population for PrEP as well as for HIV testing and care. Young women, if the images look like you, it's going to speak to you. Transgender individuals. So what does Heat do? How are we structured? We've been around since 1992. Wasn't that long after we were founded that Michal came to visit me in the clinic. This says 13 to 24. We're actually 13 to 29. Again, the one-stop shop model. And these are the populations that we're primarily focused on. And we look for high-risk youth for all of these services. And in addition to all the sexual health services, we have gender-affirming services, hormonal services for transgender people, and working with them as well. That's one population I will work with families on because I get a lot of parents bringing their 14 and 15-year-olds saying, help me. So we bring them in for hormonal services. This is from our website. If anybody in Brooklyn is watching, you'll they'll be thrilled to know that I'm promoting the HEAT website, but it's heatprogram.org. I noticed there was a pamphlet I took from downstairs. It said the same exact language, PrEP Revolution, for the lighthouse here. These individuals are what we refer to as PrEP ambassadors. We do this PrEP Aware Week. PrEP Aware Week campaign once a year, which is funded by the state of New York. And we talk about the PrEP, what is Brooklyn is PrEP, that's the name of our campaign. And it's both at the HEAT program and at the PATH Center at another hospital, Brooklyn Hospital Center. I've managed to work in both. Sometimes you need to work in more than one place to make a living, right? So maintain your salary. But it's a similar hospital, so we promote PrEP there as well. And we're talking about the daily pill or the once every 2 month shot, but we're now giving the lenacapavir, the once every 6 month shot. And we have a hotline. There are 2 people whose phones this hotline hits. Mine is one of them, but I have my phone off here, so hopefully Damien back in Brooklyn is answering these calls. These are our PrEP ambassadors who giving you a little bit of their stories about their sexuality, what they do for a living. He's a gay sex worker and he's a health educator in an HIV program. This guy, Dylan, happens to be one of my patients as well, but I learned a lot about him just by seeing him on our website. And this is Sharad, who is a social media influencer and is a non-binary individual in terms of his gender identity, their gender identity, and has a Master of Social Work. So one of the things that we do with a lot of the young people is we want them to see value in their own life. So to have role models who are doing things like getting Masters in Social Work degrees, it's really something for them to aspire to and help take care of their own community. This is our timeline with HEAT, and we're getting close to the end, where we began offering oral tenofovir in 2013. 2017, the law changed, FDA approval for PrEP at 15 to 17-year-olds. This was an issue. The FDA hadn't approved it yet. It was hard to get insurance companies to pay for it. So getting that approval was a big deal for younger sexually active individuals. Cabotegravir came along. A month later, we had our first cabotegravir patient. And then injectable cabotegravir became the predominant form of PrEP that we're using. In June, we had a first PrEP failure with injectable cabotegravir, which led to lots of questions. And why did he fail? He failed because he had other STDs at the time. And then in September, we started using lenacapavir and still trying to figure out the best way to use it. Okay, let me show you some of our data. What does your program look like? How good are you doing? How well are you doing? What are your areas for improvement? And so on. And we didn't talk yet about doxypep. I assume folks, I know it's prescribed here, but I'm assuming folks know doxypep, what it is. Use of doxycycline to after sexual exposures to prevent syphilis and chlamydia. And we're just trying to figure out, are we doing a good job here? Are we reaching the people that need to be reached? This data, some of these slides are from slightly over a year ago, but you could see that we're hitting majority of our patients are below the age of 30. What's this guy doing out here? He was an immigrant from another country. We don't turn people away, and we managed to get people from Republic of Georgia. We have a cohort of gay men who are in their 30s and 40s coming from Iran. And our other big immigrant group that you wouldn't expect to see is gay Nigerian men. We have people who have been on PrEP since the beginning of our program, staying in care with us 120 months, it's 10 years. And most of these here are people who are more newly enrolled in PrEP. Who are we serving? Largely black population with both white and Latino populations there. 56% being men. This is men who have sex with men. And then the second largest group is your transgender women. Their sexual risks, this is condomless. This whole category here is condomless anal receptive sex. But we do serve heterosexual women, vaginally receptive, and transgender men, vaginally receptive. What's going on here? There are, among our transgender patients, I mentioned the risks are so much higher. They're such an invisible population that focusing and promoting PrEP to them, and it's a shame when they've been in care for hormonal treatment and all of a sudden they seroconvert to HIV positive. So really promoting PrEP to that population. So about half of them, when I did this last June, were on PrEP, and these were the ones that were ever sexually active. And about half of them were not on PrEP, but more than half of them are taking doxypep because it's episodic. I might have sex once every 6 months, so I'll take doxypep, but I don't think I need PrEP because I'm not that sexually active. Why were they not on PrEP? Well, I was not currently sexually active at the time. These are 4 people. Whoops, the visit was just too busy with so many other psychosocial issues. We didn't even get to talking about PrEP. Our fault. Sometimes patients are just not interested for whatever their reason. And then here, we had individuals who were in a long-term monogamous relationship. They felt that they weren't at risk, even though they were sexually active. So doxypep, and it seems that you folks do use doxypep here, not that differently than we do here. I've got the doxypep pamphlet written in Czech. And, whoops, oh no. So out of our PrEP clients, we had about 62% when I did this. This was a year ago. It's probably higher now, getting doxypep. This is just among the PrEP patients. And the whole point of this is that after we started giving doxypep, we had an increase in diagnosed infections. It only works if you take it. If you don't take it, you're going to get, in this case, it was probably chlamydia that we were diagnosing. What did we find What did we find from this study, or this evaluation? The youth clinic model is really important. We were able to engage and retain a diverse population of young people who otherwise might not go for care somewhere else. The injectable PrEP is popular. A lot of the folks switched from oral PrEP to injectable. We didn't start them on the injectable, just, we got this new option here. Do you want to try it? Yes, I hate those pills. And we think that our template for providing PrEP to young people is something that could be easily replicated. And for us, it works very well for underserved youth from communities of color. Doxypep is really easy and it's really inexpensive. And we don't get enough young women. You know, with young MSM and young transgender individuals, they're kind of focal points in community where you can access people, where they can access you. Whereas cisgendered young women, it's just half the population. It's a little bit broader. And so your outreach strategies have to be different, but the risks are high. Okay, last set of slides. I'll walk you through these and then we'll open up for questions. So this top line, this is monthly. I have no idea why these changed to Roman numerals. It wasn't how I set it up, but it's how they translated here. Total PrEP clients served. Down here is, oh my God, I'm getting lost in my own slides. DoxyPEP. You see, most of the PrEP clients are on DoxyPEP, and this orange line is all the injectable PrEP. And you can see it's slightly trending upwards, whereas the oral PrEP is slightly trending downwards. And down here is the new number of patients per month. By gender, these two lines down here are cisgendered women and transgendered men. So they're relatively low numbers there. But we have MSM here, transgender women here. And I was hoping to see less and less. The numbers down here represent gonorrhea and chlamydia, tracking the syphilis easily. A week before, I'm coming on a trip to the Czech Republic. It's a little bit more in depth, looking at RPR titers and so on, and figuring out the lab results. Was this new syphilis or is it old laboratory data and so on? So at least for gonorrhea and chlamydia, they're at low numbers, but they're still present. Again, it only works if you take it. So, all right, case study. I promised one case study which kind of tells everything about the one-stop shop model. So she's a transgender female. She's 22 years old. She wants to start hormones. At the same time, you learn she's homeless and stays mostly with friends, does not want to go into the shelter system. It's really not safe for someone like her. She has a history of bipolar disorder. She's been hospitalized for suicidal ingestion, hearing voices, and so on. And they referred her to us from her most recent psychiatric hospitalization. So not because she needs hormones, because she needs antipsychotic medications, but when she came to us, she said, I want hormones. We said, we'll give you both. Don't worry about it. We treated her for syphilis. In the past, she got treated, but she couldn't give us very clear history, and engages in sex work to buy money, to have money to buy food and clothing. We quickly assessed her for gender dysphoria, myself and the clinical social worker. We tested her for HIV. This is, we can get these results back the same day. She tested negative for gonorrhea and chlamydia, 3-site testing, urethral, pharyngeal, and anal. She had a positive RPR titer, which indicates probably old syphilis, not something new. And then we contacted the health department, and they were able to give us, from mandatory reporting, that she got treated 2 years earlier and had a higher titer before. She got treated with doxycycline for a month. Now, here, do you treat syphilis with penicillin? Of all the drugs to have a shortage of in the United States, don't ask me why, we cannot get injectable penicillin, bicillin, as we call it, benzathine penicillin. So we've been stuck treating everybody with oral medication for longer periods of time that give you GI upset and so on. Let's see, so we diagnosed her with gender dysphoria. We assessed her needs. First things first, get her housing stabilized, and her life will be much better if she has a stable place to live. Get her into stable psychiatric care, give her hormonal therapy, and address HIV, STI prevention. She had never been on hormones before, and we recommended, because of her mental illness, she get in something we refer to as supportive housing, where there are other services in the housing complex, much like we saw in this building, with a social worker on site. And she requested only to be on injectable medications, but only after she got housed. We put her on oral hormones. That's what she wanted, to be on the hormones first. So if we give her that, she'll agree to other things that we think she should be on. So she got on injectable aripiprazole, which is an antipsychotic agent, and agreed to start injectable cabotegravir. And we also discussed some oral medications, and she said once she's housed, She could be on some oral medications, and she was eventually put on oral spironolactone as part of her gender-affirming care, and the doxy-PEP once she was housed. And we connected her to our own psychiatric service in our clinic. She started on cabotegravir. She also started getting estradiol and aripiprazole. Everything was injectable. She got supportive housing within 6 weeks. She's kept all of her appointments and so on, and she shows up for these injections. So just to show what the one-stop shop does is deals with housing, psychiatric diagnosis, gender dysphoria, and HIV prevention, and that is it. Dziękuję. So are there any questions? Thank you. Are there any questions? Plus, anybody online, I don't know if you're able to see the online folks, if they're... So...
No question yet, but it was beautiful. Thank you, Jeff. And I hope we will improve also in Czech Republic the fear prevention of STIs.
I hope at a minimum that I've opened up some questions, or this presentation can stimulate some discussion here in Prague and the rest of the country to include other populations and really push for, as we've been talking since last week, for the injectable medications. I think it's a real game changer. It makes life easier. The patients like it, but these drugs are very expensive. A single injection of cabotegravir in the United States has a cash value of $3,000. If you have to get that 6 times a year, do the math, it's $18,000 treatment. It's almost as expensive as HIV treatment. So there's a lot to discuss.
I have a question, but it might be too vague or too demanding, so it should probably be a last question.
Okay, I have a question more for Milan. Maybe what the situation in the Czech Republic is it available for adolescents to get prescribed PrEP without the consent of the parent? Because it is possible to prescribe antibiotics or other things.
Yeah, we have a lot of discussion about it, and from the age of 15 is possible, yeah, because in case man or woman is like...
And can you access the data from the insurance company from the children? Because I'm not aware of that. I have never done it myself. Can you as a parent look for the data?
I'm not sure, but...
I think you can, because it depends on insurance company, but that also comes to my mind when you were talking about it, that you can see if you have this, for example, VZP application, you can see like all the bills, all the visits of you and your children as well.
However, it's not very commonly done.
Yeah, but you need to look for it. It won't come.
You need to know how to work the system.
If you have a bad parent, they will search for you.
But if you want to protect their confidentiality, you need to know how to, as I say, work the system to get around that so that parents don't necessarily need to find out. We often ask the insurance companies to send those letters to my office. They're required by law to send the letter, but they don't have to violate someone else's confidentiality, which is illegal by sending that letter. By observing one law, you shouldn't be breaking another one. So we say, can you use an alternative address? And we usually have it sent to my office. And then we give it to the young person, who usually takes it and throws it in the garbage. What is this you handed me?
I have a question about your HIV national New York State program. Are there any targets about the program? How many PrEP users you need to have to see some impact on the population level?
Yeah, there are targets, and we are not reaching them. I have other slides. I referred to the program as ETE, End the Epidemic. That's the name of the New York State program, and they have a website, the ETE dashboard. And you can actually go on there. They have targets for testing, for HIV testing, and they have targets for numbers of people that they want to see getting onto PrEP. and we are far, far below those targets. Not for lack of trying.
Do your patients see a doctor, a physician every visit, or are they being cared for by nurses only, for example?
We'd be lucky if we have one nurse who works 2 days a week, so it's usually they're seeing a doctor or what we call physician assistant. I don't think you have them here in this country, but there's someone who has less training but can see patients, prescribe, but have to work under a doctor's supervision. So there are myself, another doctor, and a physician assistant, and they usually see us. If it's a day we have the nurse there, she's usually giving the injections. If the nurse isn't there, medical providers are giving the injections. So just by default and lack of good staffing in the clinic doesn't make the hospital a lot of money, like say surgery department or a place where they can bill for procedures. So we don't get the best staffing from the hospital. We get space, we get the medications, we get the labs and so on. So they're usually seeing the doctor, but there's a difference between when you're doing what we call a PrEP injection visit and you know you have a very limited amount of time. So you're giving them the injection while you're talking to them and it's all happening kind of fast. And as we were talking yesterday, if you have to give vaccines, there's certain documentation has to go on. It becomes difficult to work without enough staff to do all these. So our vaccine program is probably a little bit more negligent or less effective than say our PrEP program. But they're pretty much always seeing a doctor. It's just a question of how much time they get. So.
Because you have the same problem like the administrative burden. So when you have to fill out everything, so do you get any help for it?
Yeah, there's a lot of administrative burden. I have really great administrative team that work with me. There aren't enough hours in the day for them to do their work. And then it's a very they handle all of our grant funding, and it's complicated when the rules are constantly changing and there's a new president in Washington and or there's a new governor in Albany and programs change and funding streams change. So it's exhausting keeping up with this. Our federal money that we're getting under what's called the Ryan White Care Act, it's supposed to expire at the end of July, and they keep telling us that we have to reapply, but they haven't released the guidance, and it's supposedly due on June 1st. So it's really stressful to keep the clinic funded. Most of the money that supports the program comes from outside of the hospital. I want to hear your vague or complicated question as you may. Oh, yeah.
There's also one online question, so we may.
I will have two short questions. First is considering PrEP users, how many of them are on Descovy comparing to Truvada?
For the oral PrEP users, the majority of them are on Truvada or the generic version of the Truvada. Usually, like I said, the renal toxicities are less of a concern in a younger, healthier body. So we don't mind giving them the drug that has more renal toxicity, and we just don't see renal side effects in that. But if somebody asks for Descovy and their insurance will cover it, we'll give it to them.
And my second question is if you had some experience with cabotegravir as a PrEP in women that are in fertile age, that they can be pregnant and then it's contraindicated, so how you deal with it?
We give HIV positive women cabotegravir in combination with rilpivirine. So we give them the Cabenuva version.
Yeah.
I haven't really been seeing it in pregnant women on PrEP
On PrEP.
as much, but in HIV positive women, and a lot of the time, in that particular case, we may be giving the injections monthly instead of every 2 months. Because the pharmacokinetics in pregnancy are different, and sometimes we'll call for a consult. I would call, although I have people available to me to answer, with more expertise about treating the HIV with these medications in pregnant women. There's a national hotline out of UCSF, University of California in San Francisco. They call you back within minutes, day or night, and they'll tell you what they recommend in terms of treatment. So a lot of times we'll call them, but the monthly treatment with the cabotegravir is something that you see frequently in pregnant women.
That's interesting.
Yeah.
Thank you. So there's actually
Question online.
question here online from Anna, and she's asking, how do you go about the conversation about gender dysphoria and gender affirming care?
That's a whole nother hour-long lecture, but what we want to do is figure out there's different levels of care for people with gender dysphoria. Some people are specifically coming into the clinic for hormonal treatment. So we go through a whole bunch of criteria which are based on the DSM-5 criteria that we use from psychiatry, and the symptoms of dysphoria need to be related to the mismatch between their identity and their physical body, persistence, at what age it started, how long has it been going on. We also ask questions how they present in the world, what's their reaction of their families, do their families know or not know, and so on. And because we're dealing with young people, some of them may walk in and very impulsive thought process, well, if you give me a hormone shot today, I'll become a girl today. And you need to spend time explaining to them, this is like a artificially induced puberty. It's going to take 2 to 3 years before you develop breasts. They get upset. But you gave me a shot, first shot last week, and nothing happened. So, well, you need to wait a couple of years before something really happens. So we will have a medical provider, social worker, case manager, engage them in care, make them come back for a few visits to make sure that they're committed, that this is something not impulsive, but something that they're going to be committed to. It's a lifelong treatment, so they need to commit themselves to it. And for those that are getting hormonal injections, can we teach them to inject at home, or are they going to sell it to their friends, or are they going to use it for themselves safely and properly? And if for whatever reason somebody can't really be trained, they're afraid to stick themselves with a needle. It's not an easy thing to stab yourself with a needle with these hormones. They're very thick and oily substances, so you need to have wide bore needles, 18, 19 gauge needles, which are painful. So those individuals, we have them come to the clinic every 2 weeks, so we keep closer watch on what's going on with their health. Dealing with their insurance is part of the process, and dealing with their housing. And we have a disproportionate number of them who have psychiatric illness, which is why I used that case. So giving them a mental health assessment, seeing if that's a barrier to gender dysphoria. If somebody is bipolar and you put them on estradiol, you might trigger depression and suicidality and so on. So you want to make sure that these problems are all stabilized and taken care of before you get them on treatment. I could spend a whole hour talking about that. Any other online questions?
No, not yet.
All right.
I'm really worried that it's going to be unclear or that it's going to sound frivolous. I know people who are relatively less vulnerable compared to the extremely underprivileged people you often work with. They are generally more or less openly living men who have sex with men,
and they technically can access PrEP, and they their primary problem is that they are extremely shy. They are afraid of the stigmatization associated with taking PrEP. Every single one of them, I believe, is concerned both about unpleasant conversations with physicians and also in group judgment, like their other friends and acquaintances with men who have sex with men. And I'm sorry, this may be like a way too complicated question. I'm basically looking for some, because you are more experienced, so just in case you have some eloquent answer, for some like rhetorical strategies, how like reassure them that if somebody judges them, they are just not being sensible. Because like what I tried to tell them, but I was not successful, is that my mindset is like, if physicians sound judgmental, they are completely not being reasonable, because my idea was, it's as if other people are traveling with their children into other countries where they risk infection by tuberculosis or yellow fever, etc. And it's obviously good to have vaccination for those diseases in those countries. It's just not sensible to judge the people more harshly, or like if they are talking to laymen. I imagine it was a good example, but I still failed. Like if somebody goes skiing on the snow, they can injure themselves, and if we skip like judgmental discussion whether somebody should ski, they should definitely wear a helmet. Like that's my kind of reason.
Less of a stigma with that conversation.
Yeah, like they are fortunately not very vulnerable, so they like technically do not actually need to convince anybody. They do not actually need to persuade anybody to like give them some sort of, provide them some kind of service, etc. They just like need to convince themselves that it's reasonable for them to justify to themselves that if they act responsibly, but from time to time they slip, so it's safer, it's better for them to operate on the side of caution and take PrEP. They just kind of need to justify it in their head.
In their own mind.
Yeah.
So there's two key points from what you're saying. One is the attitude of physicians. So if the physician takes a judgmental attitude, that person is going to turn around and walk out and not want to talk to other physicians about very sensitive topics, such as their sexuality and their sexual activities. So training physicians to have both the sensitivity and the competency to have discussions about sex with their patients appropriately in a non-judgmental way is extremely important. And so that starts in medical school. So thank you for inviting me to talk to the medical students here. That was part of what we talked about with them last week, and a meeting with them also tomorrow. Because if people feel judged or just uncomfortable with, they get some uncomfortable vibe from the provider, they're not going to want to engage in this type of service. So it becomes a cultural shift within medicine, especially when you're dealing with HIV and PrEP, to change how doctors learn to talk about this. The other thing is stigma, reducing stigma around taking this. If you're taking oral PrEP, every day you're looking at that pill. It's even worse for people who are HIV positive. When you're HIV positive, you're looking at that pill and you're saying, I hate everything about this. Why do I have to do this? You can counsel them, like, think of it as a vitamin, this kind of thing. But with PrEP, it's to avoid catching something. It's not keeping you alive. It's preventing you from getting something that could kill you. The motivation is different, but it still has a lot of stigma. And that's one of the reasons why I think injectable PrEP is so popular among my patients. They just don't have to think about it all the time anymore. Obviously there's costs, but there's also costs to having more people infected with HIV. But stigma is a big barrier that we always have to work with. There are people who are stigmatized by having an HIV-related medication like tenofovir in their house. If somebody sees that, they're going to think I'm HIV positive and I'm just taking PrEP. So these are things you have to work into the conversation. Not only do you not have to be judgmental, but you also have to be able to have a conversation around this, because that's their daily experience, and you have to validate it for them if you want them to stay on the PrEP. I hope I've answered.
Yeah.
You were about to raise your hand.
Yeah. You've shown the statistics of people, of newly infected patients divided according to ethnicity and gender or sex. Do you have any data on the social background or?
Yes, I didn't include that, because the age group that I work with are usually dependent on parents or somebody else. They tend to be a lower economic group, but if you go on the same websites I got that information from, you can see that HIV infection is also a disease of poverty. And in fact, when we report back to the federal government in Washington, we have to report income level in certain categories. It's above this amount, but less than that amount. It's like 4 or 5 different categories. They want to know, how many people are below the federal poverty level. They call it the FPL. So that information is available both in New York City, New York State, and federal government in Washington. That's real important information. Insurance status, they make us report on also, so you could find out who's got private insurance versus public insurance versus uninsured, and how is the care getting paid for, and so on. Yeah, that's important info. Do you have any questions? So anyway, I guess that's it then. This has been really exciting. I came a long way to give this talk. I put a lot of thought into what we do in Brooklyn, how it might apply here, and how it might be helpful to stimulate the discussion here. So thank you for everyone here in the room and everybody online, and I hope you folks in Brooklyn stayed online the whole time to hear me talk. They're probably happy to have me out of the office for 2 weeks, but it's really great to be here. So, and I got to meet Miss Universe. Thank you.